Hello everybody. Today we are going to discuss about heart failure with reduced ejection fraction. Heart failure is the syndrome characterized by the triad of symptoms, signs, and the objective evidence of cardiac dysfunction. So the syndrome is divided into subtype based on the left ventricular ejection fraction. So if the left ventricular ejection fraction is below 40%, this is termed as heart failure with reduced ejection fraction. So if this rejection fraction is between 40 to 45, then it is termed as heart failure with mildly reduced ejection fraction. And if it is greater than 50%, then it is termed as heart failure with preserved ejection fraction. So, heart failure with reduced ejection fraction is characterized by the overactivation of neurohormonal axis. That is, whenever there is heart failure with reduced ejection fraction, there is overactivation of sympathetic nervous system and renin, angiotensin, and aldosterone system. So the overactivation of this adaptive response is necessary initially, but it becomes maladaptive and then it results into the salt and water retention and then cascade of the deleterious consequences which is related to the hemodynamic effect and fibrosis. So whenever the patient is not into the decompensated state, we need to avoid this activation of the sympathetic and renin angiotensin aldosterone system. Now let's talk about symptoms. So heart failure is not diagnosis but syndrome with variety of potential causes. So symptoms generally related to the reduced cardiac output and signs which are typically to elevated feeling pressure. So unfortunately, non-specific nature of the symptom means that identification of heart failure with reduced ejection fraction is often made at later stage when patient is admitted to the hospital acutely. However, this represents the end of long process of chronic pressure and volume overload of left ventricle with subacute decompensation on the background of chronic myocardial disease. So acute de novo heart failure triggered by acute ischemia, myocarditis, toxin, and arrhythmia is the alternative presentation and careful history often identifies the clinical problem. Now about heart failure and the problem. Where the heart failure is suspected, serum beta type natriuretic peptide and its N-terminal component, that is NT-proBNP, should be measured and is highly sensitive but poorly specific for the heart failure. And it is used as the gatekeeper for echocardiography, and individual with the normal BNP can be investigated for the other cause of symptom. So what I want to say in this is if there is elevated pro-BNP, then there are chances that patient has heart failure. But if there is a negative pro-BNP, then we can surely say this my patient doesn't have any heart failure. So it is usually so if our pro-BNP is elevated, then our next step is to go for the echocardiography to know what is the type of the heart failure, whether it is systolic or diastolic. So what is BNP? BNP is released from the myocardium in response to the stretching force, which are related to the elevated feeling pressure. And it promotes natriuresis, diuresis, vasodilatation, and it suppresses the sympathetic nervous axis, restoring the normal loading condition. However, levels are chronically elevated in cases of heart failure and higher concentration are associated with increased risk of hospitalization and death. Now, common symptoms and signs of heart failure. Symptoms are shortness of breath, dyspnea, reduced exercise tolerance, fatigue, ankle swelling, orthopnea, and PNT. Signs are elevated JVP, third heart sound, laterally displaced apical impulse, pulmonary crepitation, and peripheral edema. Now, this American College Cardiology and American Heart Association stages of heart failures are A, B, C, and D. A includes patient at risk of developing heart failure because of presence of conditions that are strongly associated with the development of heart failure. So these patients have no identified structure and functional abnormality of pericardium, myocardium, or any cardiac valve, and they have never shown the signs and symptoms of heart failure. For example, these are the patient with the systemic hypertension, coronary artery disease, diabetes mellitus, history of cardiotoxic drug, alcohol abuse, or with the history of rheumatic heart disease and the family history of cardiomyopathy. That means A category includes the patient who are at high risk of heart failure, but at present they don't have any structural, functional, or abnormality related to the heart, or these patients are not showing any symptoms related to the heart failure. Then B, which have developed structural heart disease that is strongly associated with development of heart failure, but have never shown the signs and symptoms of heart failure. That is, these patients includes left ventricular hypertrophy, fibrosis, left ventricular dilatation of hypocontractility, asymptomatic valvular heart disease, and previous myocardial infarction. Then C includes the patient who have current or prior symptoms of heart failure associated with underlying structural heart disease. That is, these patients include dyspnea or fatigue due to left ventricular systolic dysfunction, or asymptomatic patients who are undergoing treatment for prior symptom of heart failure. Then D includes advanced structural heart disease or marked symptom of heart failure at rest despite maximal medical therapy and who require specialized intervention. That is, patients who are frequently hospitalized for heart failure or cannot be safely discharged from hospital, or patient in hospital awaiting heart transplantation, patient at home receiving continuous intravenous support for symptom relief, or being supported with mechanical circulatory assist device, or patient in hospice setting for the management of heart failure. Now, the next is NYHA classification. So this includes class 1, class 2, class 3, and class 4. Class 1 includes no limitation of physical activity, that is, ordinal physical activity doesn't cause any breathing difficulty, fatigue, or palpitation. Then class 2 includes slight limitation of physical activity. That means the patient will be comfortable at rest, but ordinal physical activity results in undue breathing difficulty, fatigue, and palpitation. Then class 3 includes marked limitation of physical activity. That means patient will be comfortable at rest, but less than the ordinary physical activity results in undue breathing difficulty, fatigue, and palpitation. Then class 4 is the dyspnea at rest. So in simple language, if I want to explain again, then NYHA class 1 means there won't be any limitation of physical activity, patient will be stable. Class 2 means patient will be having breathing difficulty after performing the activity which are more than the normal for the patient. Stage 3 includes patient will be having breathing difficulty, fatigue, palpitation after performing normal physical activity, and stage 4 means dyspnea at rest. So occasionally left ventricular ejection fraction of less than 40% is detected incidentally in individuals who are truly asymptomatic. So this is not heart failure by definition, but it is termed as asymptomatic left ventricular systolic dysfunction, which is equivalent to the stage B. Once the patient has been identified as heart failure with reduced ejection fraction, the underlying etiology of this left ventricular systolic dysfunction should be solved. Most commonly, this will be related to the ischemic heart disease or idiopathic dilated cardiomyopathy. So there are two types, ischemic and non-ischemic. So ischemic includes either subendocardial infarct or transmural infarct. The non-ischemic etiology includes idiopathic dilated cardiomyopathy, myocarditis, HOCM, right ventricular pressure overload, or it could be infiltrative disorders like sarcoidosis, myocarditis, and Chagas disease. So patient with the chronic impairment of left ventricular systolic function may well have complete resolution of symptom and left ventricular ejection fraction with appropriate therapy, but they are at risk of recurrent decompensation, and continuing medical therapy is supported by experience and randomized trial evidence. So more rarely, patient may present with reversible underlying cause of left ventricular systolic dysfunction such as Takotsubo cardiomyopathy, tachycardia-related cardiomyopathy, thyrotoxicosis, and others. Critical ischemia corrected by revascularization may reverse heart failure with reduced ejection fraction in carefully selected patients, but identifying individual in this category challenging, and literature would not support routine revascularization in the absence of anginal symptoms. So the key understanding the etiology of underlying heart failure with reduced ejection fraction is care is history, physical examination, which is combined with the appropriate investigation. Cardiac MRI is increasingly used to identify specific appearance related to the various potential etiologies according to the pattern of myocardial scar following administration of gadolinium contrast. So, if I want to summarize this, then if we are seeing the patient with heart failure with reduced ejection fraction, then either it could be because of ischemic etiology or non-ischemic etiology. Then our job is to take proper history, perform proper physical examination, echocardiography, and then direct our investigation accordingly. So if we are highly, if from our history, physical examination, if we are highly suspecting the cause, underlying cause of this heart failure with reduced ejection fraction is ischemic, then go for the coronary angiography. But from our history point of view, from physical examination, if we are strongly suspecting the cause of our heart failure, this reduced ejection fraction is non-ischemic, then go for the investigations like MRI. Now about the treatment. Patient with the heart failure with reduced ejection fraction should be engaged with the disease management program. So acute heart failure begets the chronic heart failure and follow-up after stabilization of symptom is key to improving outcome. So prognostically, beneficial medication require multiple dose titration and careful monitoring. Now about pharmacological management. Diuretics. Loop diuretics are the first line treatment and recommended in case of acute heart failure. Dose escalation may be necessary during decompensation associated with the time of intercurrent infection, acute coronary syndrome, and acute arrhythmia. High doses or intravenous administration may be required with renal impairment where patients are diuretic resistant or where there is reduced bioavailability associated with the GERD. In the congested state, elevated serum creatinine commonly related to reduced glomerular flow rates due to high pressure in the efferent arteriole as a consequence of elevated central venous pressure. So, escalation of intravenous diuretic therapy rather than dose reduction is indicated in this context. Where cardiac function is improved by other therapies, diuretic dose may be need to be reduced as well as at times of insensible fluid loss. For example, during period of extreme heat and the diarrheal illness. Addition of thiazide diuretic to encourage natriuresis by blocking reabsorption in distal convoluted tubule can be helpful in diuretic resistant patients. So these patients will need close monitoring of the electrolytes and the low threshold of for potassium replacement. Now about four pillars of disease modifying treatment. So neurohormonal model of heart failure is key to understanding the efficacy of disease modifying medical therapy and it's summarized in following. So more recent evidence for significant benefit related to reducing heart failure admission associated with SGLT2 inhibitor expands our understanding of pathophysiology of heart failure and cements this agent as a fundamental keystone in the management of heart failure with rejection. So remember one thing, whenever there is a patient with heart failure with reduced ejection fraction and if it is in the decompensated state, then this response of then this sympathetic overactivity or the activation of renin angiotensin mechanism is helpful in tackling this decompensated state. But once that decompensated state is over, then it is maladaptive and we need to block that. So many patients with heart failure with reduced ejection fraction have a degree of renal impairment prior to the commencing therapy. So due to this mode of action, some further deterioration in renal function is to be expected with renin RAS system inhibitor, and this usually stabilizes and ultimately the renoprotect. Acute kidney injury is often cited as a cause of discontinuing RAS inhibitor, but such a reflex response should be avoided in favor of careful monitoring and consideration of other factors leading to the reduction in estimated GFR. Occasionally, hyperkalemia may limit RAS inhibitors, and newer potassium binding agent may have role here, but prognostic benefit of this approach is yet to be determined. So we'll have discussion on our uh, four pillar treatment of heart failure with reduced ejection fraction. So first one is AC inhibitor, ARB, and RB. Impaired cardiac output reduces renal perfusion, which triggers the renin release from juxtaglomerular apparatus, which promotes conversion of tensinogen to angiotensin 1. So AC inhibitor metabolizes this angiotensin 1 to angiotensin 2, resulting in reabsorption of sodium and water, rising aldosterone and ADH level, causing arterial vasoconstriction. So this mechanism initially maintains cardiac output via feeding pressure, but may ultimately result in increased volume expansion, overwhelming Frank-Starling mechanism. So AC inhibitor is recommended as first-line treatment, demonstrating overall reduction in the mortality of 23% and worsening symptom by 35% compared with placebo. Some patients cannot tolerate AC inhibitor, most commonly due to dryness. So in that case, ARB, that is angiotensin 2 receptor blocker, have been used as second-line agent due to less robust mortality data from the clinical trial. But in modern era, conversion to sacubitril valsartan should be considered before resorting to the use of ARB alone. Combine ARB and RNA therapy with sacubitril valsartan has more recently demonstrated superiority of AC inhibitors in well-treated patient with angiotensin receptor in patient with heart failure with reduced ejection fraction. Sacubitril inhibits neprilysin, which is responsible for breakdown of natriuretic peptide, thus increasing circulating levels and promoting natriuresis and other positive effect of BNP, which is described, which we have already discussed. So sacubitril valsartan had 16% relative risk in the reduction in mortality. So combination therapy of AC and RNA is contraindicated due to risk of angioedema and washout period of at least 36 hours between last AC inhibitor dose and first RNA dose is mandated. Otherwise, side effect profile is similar to AC inhibitor, but with higher rate of symptomatic hypotension and potential for overdiuresis. So most often the effect of sacubitril valsartan are beneficial and may report rapid symptomatic and quality of life benefit. In addition, incidence of cough, hyperkalemia, and elevated creatinine are lower. So AC inhibitors that can be used in heart failure with reduced ejection fraction are captopril, which is in the dose of 6.25 3 times a day, enalapril 2.5 2 times a day, lisinopril 2.5, ramipril 1.25, and tradalafil. Now our second pillar therapy. If I want to summarize, so nowadays rather than AC inhibitor, we are preferring ARNI in the form of sacubitril valsartan. So the next pillar, next pillar therapy is mineralocorticoid receptor antagonist. MRI block the effect of aldosterone, which is ordinarily promotes salt and water retention, and has direct profibrotic effect on myocardium. So spironolactone and the eplerenone both reduces relative mortality in heart failure with reduced ejection fraction by 30%. So spironolactone is the broad-spectrum mineralocorticoid blocker with side effect relating to its anti-androgen property, particularly in men. It is also effective antihypertensive agent and can be prescribed with the dual indication. Eplerenone is the specific aldosterone blocker, so is better tolerated, particularly in male and in those with a lower blood pressure. So eplerenone specifically has been shown to reduce mortality in patients with heart failure after myocardial infarction. Mineralocorticoid receptor antagonist can be useful to prevent hypokalemia, but these are contraindicated in patients with hyperkalemia and monitoring electrolytes is essential. Now our pillar 3 therapy is the beta blocker. So sympathetic overactivity is the hallmark in the heart failure with reduced ejection fraction. Increased peripheral vasoconstriction and elevated heart rate attempt to maintain cardiac output and vital organ perfusion, but may ultimately malady. So it may worsen myocardial ischemia, and high catecholamine level may increase uh, myocyte automaticity, which increases the risk of malignant ventricular arrhythmia. So the use of selected beta blocker is therefore recommended for heart failure with reduced ejection fraction and is results in the relative mortality reduction of 35%. The use of beta blocker may be worsened in the acute heart failure, and so clinical assessment is required to ensure that patient with heart failure with reduced ejection fraction is not decompensated at the time of beta blocker initiation. So patient often feel less well for 48 to 72 hours following initiation of beta blocker and dose escalation, and should be warned of this to improve compliance with life-saving therapy. So patients with heart failure with reduced ejection fraction have decompensated on stable dose of beta blocker, and they should be continued at same dose while managing the decompensation. Dose titration should be maximum tolerated with target resting heart rate of 60 to 70 beats per minute in sinusoid. So use of beta blocker in patient with heart failure with reduced ejection fraction with atrial fibrillation is recommended. Aggressive rate control does not appear to provide any significant benefit when compared with more modest rate control. Some patients may not tolerate beta blocker at high doses, and where heart rate remains 70, then if channel blocker, then this IF channel blocker, that is evaporating, may be used to slow sinus rate and improve symptom and mortality. Our fourth pillar is SGLT2 inhibitor. So SGLT2 is well established hypoglycemic agent which are used in the management of type 2 diabetes. They promote glycosuria and natriuresis by reducing reuptake of glucose and sodium in proximal renal tubule. So recent evidence has establishes this class of medication as a key therapy in heart failure with reduced ejection fraction. Both dapagliflozin and empagliflozin have demonstrated 25% relative risk reduction when compared with placebo in a combined endpoint of worsening heart failure and cardiovascular death in otherwise well-tolerated patients with heart failure with reduced ejection fraction, both with or without diabetes. So current ACC and AHA and ESC guidelines strongly support the use of SGLT2 inhibitor at the early stage of the heart failure with reduced ejection fraction. There is potential for overdiuresis with concomitant use of ARNI and loop diuretic, and careful clinical assessment is required in these circumstances. Now about adjunctive therapies and impact of comorbidity. Comorbidities are common in patients with heart failure with reduced ejection fraction, and their management should be optimized alongside the initial heart failure therapy. So cardioselective beta blocker are safe to prescribe in all patients with chronic obstructive lung disease. AC inhibitors are generally recommended where renal dysfunction complicates heart failure with reduced ejection fraction. Where AC inhibitor cannot be used due to concern over renal dysfunction, and then combination of nitrate and hydrolyzine has same evidence for benefit. Now about atrial fibrillation and the heart failure with reduced ejection fraction. A direct oral anticoagulant will generally be recommended in all cases of heart failure with reduced ejection fraction which are complicated by atrial fibrillation. Restoration of sinus rhythm may confer benefit in this patient, but this remains the controversy. Cardioversion, often facilitated by amiodarone, may be considered to improve symptoms. Dronedarone and flecainide should be avoided. Catheter ablation may have role in improving prognosis, but the data remains conflicted and careful patient selection by appropriate multidisciplinary review is recommended. So digoxin can be useful in addition to beta blocker to improve rate control in atrial fibrillation, particularly in less ambulant patients. It can also be used in those patients who remain symptomatic despite optimal medical therapy, where even 62.5 microgram once daily can give some symptomatic relief and is associated with reduction in hospitalization. Now about device therapy. Patient with heart failure with reduced ejection fraction, they are at risk of death from both progressive pump failure and sudden arrhythmia. So, what can be done to prevent this arrhythmia and sudden death? So there are two devices options for CRT. Now we will see when to use implanted cardioverter defibrillator and when to use CRT. So this implanted cardioverter defibrillator, that is ICD therapy, can abort sudden cardiac death via rapid detection and treatment of malignant ventricular arrhythmia. Such a devices are recommended for primary prevention when overall prognosis in otherwise estimated to be at least 1 year and LV ejection fraction is less than 35%, despite best medical therapy with AC inhibitor, beta blocker, and MR. So the next is ICD can be delivered via transvenously or subcutaneously. Now the next is preventing pump failure. Cardiac resynchronization therapy can be delivered as pacing system alone or can be combined with ICD. So the procedure involves delivering an left ventricular lead via coronary sinus. If the QRS duration is greater than 140 on resting ECG, then it is a strong predictor of response to CRT in terms of improvement in symptom and prevention of heart failure admission and improved prognosis. Correction of dysynchrony is a complex phenomenon and is dependent on multiple factors, including LV and RV lead position as well as optimum device program. All patients with heart failure with reduced ejection fraction with prolonged QRS should be considered for CRT and ICD. So the statement recommended the use of CRT earlier in heart failure pathway and considered its complementary to medical therapy if dysynchrony is significant. So in simple language, if I want to tell, then ICD is recommended when the QRS complex is narrow or if there is no evidence of LBB. And CRT is recommended when there is prolonged QRS or if there is evidence of LBB. Thank you guys.